and welcome everybody. I'm glad to be here today. As you have heard, my name is Alice Mwangi and I work for Operation Eyesight as a country manager for Kenya. And I'm excited to be here today to talk about sustainability. So sustainability is critical and integral part of program design. And you'll agree with me that it is a terrible mistake to start thinking about how a project will be sustained at the end of it. So for us here in Operation Eyesight, sustainability is key to us. And I will attempt to demonstrate how sustainability has been entrenched in the SiB supported project in Kenya. So the term sustainability in eye care is seen as the ability to maintain the benefits achieved by blindness prevention program long after the end of the program support. While sustainability can be looked at from different angles and described using different components, my presentation will focus on sustainability in context of Operation Eyesight, Seeing is Believing supported project in Kenya. So the term I will also focus on 4 areas when looking at sustainability. And the 4 areas are in health management and information system, in health financing, human resource for eye health, and lastly, supply chain. But before that, allow me to give you a preview of Seeing is Believing project in Kenya. And this is a 4-year project that started in the year 2014, and it will end in 2018. And as you can see from the presentation, the title of this project is the Rift Valley Province Prevention of Blindness Program. And for those who do not know Kenya, actually this region is mainly on the western side of Kenya, and also part of the southern part of Kenya. And the goal of this project is to contribute towards elimination of avoidable blindness in Kenya by strengthening community outreach program. This project has 3 objectives. And the first one is on quality, and that quality and sustainable eye care services are made available in the project area. Secondly, the project seeks to build the capacity of primary, secondary, and tertiary level facilities so that they are strengthened to provide quality services. Lastly, but not the least, the project focuses on integrating primary eye care into general public health care. So this project actually is embedded in the Kenya Ministry of Health, health system, and the county government health system. And we work closely with 7 secondary and 1 tertiary level hospitals as our partner hospitals, as listed below, namely Washungishu, Iten, Kapsabet, Kitale, Kapenguria, Narok. Narusora is actually a satellite clinic of Narok, and Moi Teaching and Referral Hospital. Just to highlight some of the project achievements, and noting that we're in our 3rd year of the project implementation, we have been able to screen more than 250,000 people. We have provided treatment for more than 200,000 people. We have done surgeries, about 23,000 surgeries. 8,358 of them are cataract surgeries. In terms of infrastructure development, we were able to construct an eye unit from scratch, and this eye unit is now operational and providing services. It's fully equipped. We were able to identify equipment gaps in the other 6 hospitals and provided equipment. And in terms of HR, human resource development, we were able to train 17 ophthalmic workers, 6 of whom are cataract surgeons, and 11 of them are ophthalmic nurses. So let me take you through the components that I had earlier mentioned in regards to project sustainability. Operation Eyesight does not run parallel health management and information system, but we use partners HMIS to extract our reports through the use of a tool that we share with them. And this tool is able to disaggregate data by sex and age. And we're able to collect data that includes patients that were seen at the static clinic and during outreaches. It's also able to collect a summary of diagnosis, including refractive errors, the glasses supplied, and surgical procedures. And this data that we collect on a monthly basis, we are able to analyze it on quarterly basis and 6 month basis, and again annually. And from this, we are able to show the trend, and we use these reports for planning and for advocacy. I'm happy to inform you that some partner hospitals have also started seeking feedback from their patients regarding their experiences at the eye unit, and mainly on customer care service to improve customer care. And this data, again, we analyze it and use it to improve on the quality of services being provided. Over the years, we have noted improvement on the reporting, and this could be as a result of the project monitoring system that we put in place from the beginning of the project. Eye surgeons are also encouraged to record their surgical outcomes, and they are now conducting, they are monitoring their cataract surgical outcomes. And this data is analyzed to show trends in quality of cataract surgery. And again, this data is used to make, this report, once analyzed, is used to make decisions on where to invest when it comes to improving quality of services. So the second component I would want to look at when it comes to sustainability is on health financing. And just to give you an overview of health financing in Kenya, I would like to mention that Kenya for a long time has employed user fee system in health financing. And in recent years, the government opened up National Hospital Insurance Fund, which is commonly known as NHIF. So NHIF registers all eligible members, both in the informal and informal sector, and it is compulsory for those in the formal sector. But the membership is open and voluntary for those in the informal sector and retirees. So senior citizens aged 65 years and above and people with disabilities benefit from the free NHIF cover. And this NHIF cover, it covers both inpatient and outpatient, including surgeries, up to USD 5,000 on pre-authorization. So Operation Eyesight supported hospitals have both the health financing system in place, that is the user fee, and HNIF. And we have been able, again, to negotiate for subsidized fee for cataract surgery in all our partner hospitals to reduce barrier to access due to cost. The other thing that we do is to support the hospitals to provide free surgical eye cams to reach the poor populations in remote areas. Though we provide, we support items, the number visiting the static clinics have increased over the years. It is also important for me to mention that we have introduced a revolving fund for optical services in some of our partner hospitals. And while these services, the optical services, are free and open to the general public, we have also tapped NHIF cover in some of them. And we are trying to sensitize the elderly people to take up the NHIF cover, as it has recently started covering cost of surgery. The third component on sustainability I'd want to talk about is on human resource for eye health. And this project supports capacity building of hospital partners through training of ophthalmic workers. The project, in collaboration with the hospital management, is able to identify gaps in human resource. And we are able also to identify people who are interested in pursuing courses in ophthalmology. And over the years, as I had mentioned in my introduction, we have been able to support training of clinical officers and ophthalmic nurses. So after the completion of the training, these people are deployed to their stations, some to initiate eye care services in their hospitals, while others to join an existing team. So the trained ophthalmic workers are government staff, and they will continue providing services long after the funding comes to an end. The fourth component I'd want to talk about, and actually the last, is the supply chain. And just to give you an overview of what's happening here in Kenya, government hospitals procure their supplies from the Kenya Medical Supplies Agency, commonly known as KEMSA. And in 2016, KEMSA revised its list to expand the essential drugs list for eye drops after concerted advocacy by eye care NGOs in Kenya. And also to mention that we have a strong INGO forum in Kenya that's made up of other eye care NGOs like Fred Hollows, SiB, CBM, and COEXA. And we are able to identify issues on advocacy and run with them. We are also lucky that we work closely with Ophthalmic Services Unit, which is a unit of Ministry of Health, who actually has been holding our hand to show and also help us in engaging the ministry. So operationalized supported eye units have started including eye drops in the hospital order. These are now available at KEMSA. However, we are experiencing some challenges in that some consumables like the cataract kits, trachoma kits, IOLs are not available at KEMSA. But we have intensified advocacy with the county government so that we can prioritize the eye needs of eye health. But also, we are trying to connect the county government to possible suppliers for these consumables and IOLs so that they can be able to purchase them long after the funding comes to an end. So in conclusion, I just want to mention that making a project sustainable is a process. It has to start from the very beginning of the project inception and design, as I earlier mentioned. It has to continue throughout the project implementation. And I'd want to say that even after the funding has come to an end, it's important to pursue it to ensure that the gains of the project are not lost. So thank you for listening to me.
Thank you, Alice. That was a really interesting presentation, especially in the areas of embedding the programme into the existing health system and engaging with the National Hospital Insurance Fund. And thank you for sharing such a great advocacy success. It really shows the impact of NGOs in country coming together for joint advocacy. So thank you so much for that, Alice. Secondly, Thank you. Let me introduce Deborah Tigeri, who is the country representative for CBM Zimbabwe. So I'm now going to make Deborah the presenter and hand over the controls to her, and she'll take you through her presentation. So again, if you sort of just bear with me a minute, give controls to Deborah. The mouse always takes system. Right, okay. So Deborah, I should be making you the presenter. It just sort of takes a moment or two just to click through. It's waiting to view Deborah's screen. Yeah, sorry for this slight delay. It sort of always just takes when you want to go to your webinar, it just takes a moment just for kind of the screen to come through, but it should be worth it in the end. Yeah, and I think, Deborah, if you've had a little box come up saying to accept the screen, then you can just click on accept and it should come through.
All right.
Yeah, that's it. Perfect.
Okay, thank you, Susan, and welcome everyone. Yes, my name is Deborah Tigere. I'm the CBM country representative in Zimbabwe. I'm going to talk about sustainability, which is our topic for today, but sharing our experiences on the SiB project implemented in Zimbabwe. Okay. Right, I'm going to give you a background of the eye health conditions in Zimbabwe. According to the National Eye Health Strategy 2014 to 2018, eye health diseases or conditions are amongst the top 5 causes of outpatients department and also a major cause of morbidity. And the blindness prevalence is estimated at 1% of the total population, of which more than 80% is avoidable, and cataract alone causing blindness in 62,500 persons. This is according to the WHO estimates. Now, the SiB project in Zimbabwe started in 2015, and it is in its last year of implementation, and it is, of course, titled Strengthening Vision 2020 in Northeast Zimbabwe, supporting 3 eye units, namely Norton Eye Hospital in Mashonaland West Province, Sakuba Eye Hospital in Manicaland Province, and the Sekuru Kaguvi Children's Eye Unit, which is based in Harare, and a major tertiary referral center. Now, this project has 4 objectives, which are, of course, increasing the quantity and improving the quality of eye care services for adults and children. Another objective which focuses on the building capacity of eye health workforce at primary, secondary, and tertiary levels, as well as the infrastructure for delivery at a secondary and a tertiary level. This is mainly the reconstruction or refurbishment of the specific eye units I talked about. And of course, the last objective being to ensure that all eye care services are inclusive. Now, let's talk about sustainability.
Deborah, could I just jump in a second? Are you able to click through your slides? Because I think we can view your screen. So are you able to click through whilst you're speaking so we can have a look at the screen that you're kind of speaking on at each time?
Sure. I am actually scrolling through my slides. I don't know whether it's showing from that end.
No, it's not. Okay, no problem. I might take back control and do it from my side.
Okay, it's showing now. Show screen.
No, it's not. Okay, I might bring it back to me and then I can then click through.
Okay, sorry about that.
No, my fault. If you people show my screen. Yeah, okay. So please continue and I'll bring up the screen.
Okay, that's fine. If you can, sorry about that. Participants, I will talk about sustainability. The ability to maintain services or benefits beyond the lifespan of the project. Now, the major challenge when it comes to sustainability in developing countries is the issue of ownership of the projects, the issue of policy support, economic challenges, among other environmental and external threats. And as my other colleague talked about earlier on, it is important to consider sustainability right from the design stage through implementation as well as monitoring. But what is it that we want to try and sustain? We need to sustain some level of service provision beyond the lifespan of the project. We need to consider positive change and see whether it can be sustainable. Consider new initiatives and look at whether these new initiatives can also be sustainable. An important aspect to consider when it comes to sustainability as well, as I mentioned earlier, is the ownership of the project objectives or the achievements. And under SiB project in Zimbabwe, in order to achieve ownership, we involved the Ministry of Health and Childcare right from the design through the implementation as well as the monitoring of the project. The partners involved also participated in the National Prevention of Blindness Committee, which is the national committee that looks at eye care services in Zimbabwe. We also involved the patients in terms of the patient satisfaction survey, which is being administered at the 3 eye units in order to get continuous feedback on service provision and on ways on how to improve our services, addressing gaps and issues related to the services provided in these 3 eye units. Coordination and awareness is important because we realize that in the provinces which we relied on in terms of identification, screening, and referral of patients, they did not understand the project from the onset. So it was important for us to hold coordination meetings, raise awareness, for them to have a buy-in in terms of what the project was all about and what the objectives were all about in order to support the project implementation and also to see the vision beyond the project. An important aspect of sustainability is financial or economic sustainability. And each time we think about sustainability, we always think about the financial sustainability because it plays a very important role in terms of how the services will be provided and the ultimate goal. Now, when we talk of financial or economic sustainability, we need to consider the project budget and whether the project budget has actually achieved its purpose. We are basically saying with a very minimal budget, which does not achieve the purpose, it becomes very difficult to talk about sustainability. Now, I'm happy to say that the SiB project was very comprehensive. It looked at the provision of consumable drugs, equipment, instruments, training of ophthalmic nurses, the training of technicians. So it was quite comprehensive, refurbishment of eye units, and I think it served its purpose. Now, in Zimbabwe, we have a policy, a health policy, that states that children under 5 years and adults above 65 years can access health services in general, including eye health services, for free. However, under the SiB project, we also managed to negotiate the fee structure with each individual hospital to make eye care services affordable in the context of the SiB project, on condition that we were providing consumables, we were training the health personnel, we were providing equipment, and hence this took longer than expected. However, it was important to think about it and to ensure that it was implemented if we were going to increase the number of people accessing services and also push for sustainability in the long term. For example, we managed to negotiate the fee for cataract eye surgery for children from $400 to $40. in order to enable an increase in the access to eye health services. In the short term, yes, we managed to achieve our cost recovery by increasing the access to services. But this is something that we need to consider and think about more as we come to the end of this project. Now, the ability of the government to take up its services initiated during the project funding is important. It is crucial. Zimbabwe is currently experiencing economic challenges, mainly cash shortages, high cost of living, which has affected the number of people accessing eye health services. And for us to think that the government will take up these services in the short term might be very tricky. In fact, we need to consider continuous funding through medium term and see if we can achieve financial economic sustainability. Ideally, the government is supposed to be providing consumables in this hospital, and it has not been forthcoming because of the economic constraints. Hence, the project has had to take over such provisions. In Zimbabwe, we have a non-communicable diseases department under the Ministry of Health and Child Care, and recently we have had a review of national health strategy 2016 to 2020, and in this national strategy, they have prioritized NCD, or non-communicable diseases, as priority number 2. However, we also noticed that there's very little emphasis on eye health as compared to diseases like cancer. The Ministry of Health and Child Care, I must say, I commend them for also providing an essential resource, or supporting an essential resource, which is the human resource, as well as other utilities. We've also had to capitalize on support systems, for example, the health information system and other finance support systems. So I must say this is important when it comes to sustainability. Now, thinking about services without subsidy is very difficult at this stage, like I mentioned earlier on, because of the current political and economic situation. However, potential funding is still necessary in the midterm. What the project also tried to achieve was reducing the patient out-of-pocket payments, for example, the cost of transport for patients, and ensuring that the eye care services are well coordinated by having a coordinator situated in all these eye units to ensure that a patient doesn't travel all the way to a hospital for cataract surgery without knowing or understanding what they're looking forward to, hence wasting their much-earned little income. We also supplied a vehicle to support the referral of patients from furthest districts, also out to the poorest communities, in order to reduce their out-of-pocket payments, and at the same time ensuring that they also get cataract surgery. In Zimbabwe, we have a failed health insurance. We don't even think about health insurance. It's not formally employed and contributing towards one. So it becomes very difficult for patients to access services if you're not formally employed and contributing towards a health insurance system. Now, looking at institutional sustainability, another component of sustainability, under the SiB project, we looked at policy. In other words, the development or the design of the SiB project was not out of context in terms of the national eye health strategy in Zimbabwe. And this is important each time we think about sustainability. You need to look at the existing policies. However, of course, in as much as our government is facing economic constraints, the budget may not be forthcoming. But the fact that we have good policies, you never know in the long run, when there is a good economic turnaround, there can be a provision made to support eye health services. All I'm saying is policy priorities should be consistent with the project objectives or the project design. The training of health personnel took place at primary level, where we were targeting the village health workers, who are an important cadre in the primary health structure in Zimbabwe in terms of awareness the identification and referral of patients. We also trained ophthalmic nurses in the various distal provinces on refraction and diagnostic skills in order to enhance their skills and also support the referral to tertiary, as well as to ensure that patients who require cataract surgery are actually attended to. At tertiary level, we trained ophthalmic nurses and ophthalmologists on low vision training. I must say that under the SiB project, this was a new initiative. In Zimbabwe, we did not have low vision services for children. Hence, with this project, we have managed to achieve a new initiative, which I see going beyond the lifespan of the project. The project basically used the existing primary health structure in terms of identification referral, as well as I mentioned earlier on, the existing health information system. So we did not invent the wheel. We did not create parallel structures. We also capitalized on the cataract surgical outcome report, which is used by ophthalmologists to monitor the quality of surgery. I'm happy to say that we now have in-country statistics when it comes to eye care. This was because of the rapid assessment of avoidable blindness research that was conducted in 2016, and we are still to share the results as soon as they are endorsed by the ministry. For years, we have been referring to WHO estimates, and through this RAB survey, we will be able to inform future planning and also use it as a proxy to determine objectives or activities that need to be implemented in terms of eye care services. We also improved the existing facilities, which is the easier part when it comes to sustainability, in terms of refurbishment of the eye units, reconstruction of one of the biggest eye units in Mashonaland West Province, and I see this improving the quality of services provided, the space that is there, the flow of patients. We have also involved the disabled people's organizations in Zimbabwe to conduct an accessibility audit of these units to ensure that different impairments or different types of disabilities are included into these people with different impairments are able to access services in these refurbished or reconstructed eye units. Now, the provision of equipment and instruments was one other factor that we included under the SiB project in Zimbabwe. And the most importantly, we also trained instrument technicians, because there's always the issue of the room of broken toys, where each time you get to an eye unit, they open this room and it's full of broken slit lamps, probably that need just a bulb replacement. And in order to ensure sustainability and improvement in terms of quality services and provision, we ensure that at least 3 technicians were trained under the SiB to cater for the repairs and maintenance of ophthalmic equipment and instruments. And I must say these technicians are not just going to be restricted to the 3 eye units where they're currently stationed, but will provide a service to the eye units in Zimbabwe as a whole. Now, when it comes to the supply chain, I mentioned earlier that the project also provided drugs and consumables, the cataract kits. We relied mainly on the importation of cataract kits from Oralab, India. We had challenges initially in terms of importation of these cataract kits because of the Medicines and Control Authority of Zimbabwe regulations. For suppliers to supply drugs in Zimbabwe, they have to be accredited by the MCAZ, and it took time for one of our big suppliers, which is Oralab in India, to be accredited. But with the partnership with the Ministry of Health and Childcare and through the NPBC meetings, we managed to have a breakthrough on this. However, because of the restrictions, not all eye care drugs can be imported. As a result, we also rely a lot on local procurement to complement these cataract kits. In addition, we have what we call the EDLES list, which is the essential drug list in Zimbabwe. What we also realized was that they were not prioritizing eye care drugs. As a result, the national pharmaceutical company in Zimbabwe did not have most of these drugs in store. So already there was a challenge. But I must say that we have managed to achieve the number of cataract surgeries based on the importation of these cataract kits and complementing with local procurement. However, I believe that through advocacy efforts with the Ministry of Health and Childcare, in conjunction with the MCAZ, we can actually achieve more in terms of having more suppliers accredited by MCAZ. Now, when it comes to social cultural sustainability, we managed to promote community participation. I talked about the trainings conducted by the village health workers as part of the awareness, and also to promote identification and acceptance by the patients. You find that when not everybody is willing to go for surgery, there is always this barrier, one of it being fear. And in order to address this barrier, we really capitalized on this important cadre who is recognized in the communities, well respected. And according to the primary health strategy of Zimbabwe, you find that, of course, they are trained on eye care, but also trained on maternal health, they are trained on ENT, they are trained on a number of issues. So they are a well-respected cadre in the community, and we train the same cadre in order to achieve awareness, identification of eye care conditions, as well as to promote referral at lower levels. I also mentioned earlier that we involved the DPOs in terms of the accessibility, but also in terms of raising awareness and promoting inclusive practices in the project implementation. In terms of the community eye health training that took place under the SiB project, which involved the cataract case finding, we did not reinvent the wheel. In fact, we used a model that has worked well in other provinces, Vision 2020 supported provinces. We used the same model to train the ophthalmic nurses who were to train the village health workers in cataract case finding. So it has worked very well. And also established linkages with other provincial Vision 2020 programs in order to strengthen the referral of pediatric patients. In Zimbabwe, we have 2 pediatric eye units, one of them which was supported by SiB in Harare, which serves the northern part of the country. So in order to strengthen the referral of patients to this unit, we had to establish linkages with other Vision 2020 programs, and it has worked very well. In order for them to be aware of the services being provided, for example, low vision, which was not there initially, but they are now aware that we have low vision services in Zimbabwe at Sekuru Kaguvi Children's Eye Unit. Of course, under social and cultural sustainability, we have worked very well with the local bank, the local Standard Chartered Bank in country. They have participated a lot in terms of the development of a patient management system, awareness, the design and development and production of IEC material, which was non-existent, but a lot of IEC material. So we have a very good relationship with them. And you know, the Standard Chartered Bank motto is, we are here for good. And we believe that if they're here for good, and the fact that they have a soft spot for eye health, this is a partnership that has to be considered in the long term in terms of sustainability. I would like to say that each time we think about sustainability, we have to know that this depends on the nature of the project, and it has to be included right from the design stage. And of course, it is important to consider other cross-cutting issues such as gender, equity, good governance, or poverty alleviation. Thank you for listening.
Thank you, Deborah. That was a really insightful overview of the sustainability strategies that this project is implementing. Now, we've got a little bit of time before the end of this webinar for the question and answer session. So for those of you, we've got over 30 people who've attendees. So if you're one of the attendees and you have a question either for Alice or Deborah, if you can please now type it in the chat box, and then what I'll do is I'll then give the questions to Alice and Deborah. So if you've got any questions, please, this is your opportunity now to send them across to everyone. And while you're thinking of your questions, I'm just going to pull out a couple of points that I thought were quite interesting across the two presentations, because what I thought was interesting to me was that there were some common sustainability themes across the two presentations. Sort of firstly, that both projects are embedding all aspects of the project in the existing health system. So rather than replicating systems, they're sort of embedding it within the existing system, especially at the community and primary health levels, which is so important, as often these levels of staff can help raise awareness within the community, they're based in the community, and also help with case finding and referral upwards, and it's a system that's already established, and so it can continue on an ongoing basis. Secondly, the second theme that I thought was common across both was around advocacy to increase government support for eye care within the country. So with CBM Zimbabwe using the RAB to raise awareness of the need, and with Operation Eyesight working with the other NGOs to get eye drops included into the KEMSA list. And then thirdly, the fact that both projects are engaging with various income streams. So by thinking about how to support the hospitals to work with the health insurance schemes within the countries, and how those health insurance schemes are working within the countries, as well as successfully advocating for hospitals to reduce their surgery costs, so therefore making services more accessible for patients. So they were sort of some of the common themes, but I'm sure that quite a few of you have got a few sort of questions. I can see that we've got a couple have come in, so I'm just going to start with one who's from Robin. Thank you, Robin, for that. And actually, it's a question for Alice, which is what was the uptake by the clinical officers and nurses for the training, and what factors made the training attractive? So Alice, I'm going to unmute you. So would you be able to take that question from Robin?
Yes, the uptake has been good. We have seen people who are interested in taking up ophthalmology in Kenya. What we did, we worked with the hospital and management and identified the gaps in HR, in the eye unit. And some, for instance, we identified they needed 2 more ophthalmic nurses. So we asked the hospital management to help us identify these health workers. And it wasn't a problem at all. We had them coming forward and applying for the course we have a training college called Kenya Medical Training College that offers these diploma courses. And they applied and they were admitted and they attended. So we've not had any challenges for uptake of those courses here. Robin, Susan.
Lovely, thank you. Yeah, thanks for that. That's great. And one of the questions, actually, one of the things that came across to me quite strongly in the presentations was just around that you'd both worked with, it's a question for both of you really, because you'd actually both worked with the hospitals to sort of convince them how to lower their surgery costs. I mean, the one thing that sticks in my head, Deborah, when you said from $400 to $40, which is a huge reduction. So could you talk a little bit, both of you, maybe if we start with Deborah this time and then Alice, about how you managed to go through that process of working with the hospitals to reduce their costs, and also secondly, did the hospitals, since they've done that, did they value that? Have they seen sort of numbers rise, and then therefore they think yes, that's a positive thing to do? So Deborah, do you want to take that first?
Yes, sure. It was a process, I must say, of course, negotiating with these different hospitals. So this was 3 different eye units we had to negotiate with. And of course, you'd be dealing with the hospital administration, where you have the accountants also doing their maths to see whether it makes sense. But they appreciate the fact that at the moment, because of the economic constraints that the government is facing, and the fact that they have been unable to provide basic consumables to support the provision of services, we had to also come in at a project and say, look, we are going to be providing you with consumables, we are going to be providing you with the drugs, we want to give you the equipment, we are training the health personnel. Can you at least lower the structure? And it was an indication already in terms of the statistics. The number of people who are accessing services then was very low. And now there has been an increase. And I must say they do appreciate the contribution from the project. And I'm sure they are also not regretting the fact that they had to sign these MOUs to ensure that the fee structure was lowered to enable an increase in the access to services.
Thank you, Deborah. Alice, over to you. The same question about how did you work with the hospitals and how do they see that change that's happened because of lowering the fees?
I don't think it's any different from what Deborah has mentioned. It's just engaging with the hospitals from the very beginning at the program inception, and just mentioning to them that we are going to provide them with cataract kits, the drugs, equipment, train their human resource, and therefore to make the services accessible to the poor and who are in the villages, because most of our programs are actually in the rural areas. Then we negotiated that they lower this cost. So it was more of a similar process. And again, it's something we always do every time we are going to a new area.
Thank you. That's interesting. So there's an awful lot there about agreements to be made at the beginning of setting up these programs that help kind of get that commitment from people. That's really interesting. Thank you. Just a quick reminder out to the attendees. We've probably only got about 8 minutes left. So if you do have a question, I can see we've got quite a few questions popping up now. So if you do have a question, please type it in the chat box now so you get your chance to ask your question, because I wouldn't want you to miss out. So we've got a question from Juliana Nathaniel, which was around, I think it's possibly more to do with Deborah, but Alice, do jump in if it's also related to you. But the question is, what was the criteria for you to determine children to benefit from the transport support? Because I think you mentioned in some cases you were sort of providing transport support. So what was your criteria to decide which children would get that support? Deborah, do you want to take that?
Yeah, sure. The transport that we were providing basically is vehicles in the provinces. In fact, under the SI just had one vehicle for Manicaland province. We did manage to get another vehicle for the other province. The focus was on increasing the number of cataract output in the two provinces. So it wasn't specifically for children, but the referring of patients from the furthest, the poorest communities, reaching out and bringing them to the base hospital for cataract surgery in order to increase the cataract surgical output. So it was mainly to increase the cataract surgical output from these districts that were further, where people are poor. And this coordination was done through the district ophthalmic nurses who had been trained. And remember, I talked about the awareness raising in the districts and the provinces so that everybody would be aware of the services provided with the support of SiB project. And through that, they managed to reach, working with the village health workers, those who are so much in need, who can't even afford to pay for transport to access cataract surgery. And these are the patients who were brought in by the vehicle in order to reduce the patient out-of-pocket payments.
Thank you. So that's really interesting that, again, you're working with the key people working in those areas, you know, the ophthalmic nurses and the community health workers to work. So it was sort of to think about those who are far and those that are from the from the poorer areas. That's really interesting. And Alice, did within your project, were you providing transport support to children or adults? And if so, how did you determine which ones who would benefit from that?
For us, we have a different approach to reach the people on the ground. We actually take the team. We have a field vehicle that takes the surgical team to the nearer to the people. So we identify a hospital. It could be a faith-based organization hospital or a sub-county hospital with a theater. And then people around that hospital are mobilized probably prior to the outreach team. And then those who had been identified with cataract cases or any other surgical cases are brought to that hospital, and the team conduct their surgeries there. So for us, we don't ferry the patients to the hospital, but rather bring the surgical team nearer to the people.
Okay, thank you. That's interesting. Okay, so we've got another few questions that have come through. They're sort of coming thick and fast now, which is lovely. So again, do send us your question if you're interested. I've got a question for Alice actually from Anne Ebery, and she's saying, she's asking Alice, are spectacles costs covered by the NHIF, and if so, at what percentage?
The NHIF spectacles currently is covering the civil servants. Those are mainly government people who are working in government institutions, and it covers the full cost, not a percentage. And I think it goes up to about let me just do a quick calculation. Up to about $200. But we also are trying now to ensure that this is open to everybody. So even when it's just open to a section of, a group of people is good enough because it was not there at all. But now that is an entry point to ensure that it's open to everybody.
Great, thank you. That's lovely. We've got a couple of questions about advocacy here, so I'm going to read both questions, and then one is for Alice and one is from Deborah. So Deborah, I'll do the question. I'll do the two together, and then we'll do Deborah first, and then Alice. So I've got a question from Herbert Dola for Deborah, which is talking about advocacy. So he's asking, how did the Zimbabwe team manage to convince the government with the supply to? Oh, actually, this is for Alice because it's around including the eye drugs in the supply chain. So I think it's also relevant for you, Deborah, as well, because you did do a lot of work with the government to kind of get the importation of goods. So it's sort of around how did you work for both of you, really? How did you do that advocacy with the government, and how do you work with them to, I suppose, for the Zimbabwe project, get the importation of materials, and then for the Kenya team to get the inclusion of eye drops into the sort of government drug list. So Deborah, shall we start with you?
Yes, yes, we did a lot of advocacy with the Ministry of Health and Childcare regarding that, who were very supportive and in agreement to ensuring that we get adequate supplies of eye care drugs. However, the challenge was the regulatory body, which is the Medicines and Control Authority of Zimbabwe. And when it comes to regulations and drugs, you cannot break the rules. So we had to do it the right way. We had to engage the supplier to meet with the Medicines and Control Authority of Zimbabwe and enable a site visit and certification of the supplier. So in as much as we did a lot of advocacy, but we also had to do it the right way because of the regulatory body. And we had to make sure that the supplier was accredited. However, as I mentioned earlier, there is need to still do more because we have all these other drugs that are not on the ED list of drugs, priority drugs in Zimbabwe for eyes, which we believe if that was the case, then we wouldn't be struggling with importation of drugs.
Thank you, Deborah. Okay, Alice, over to you. Do you want to talk a little bit about the advocacy that you did within Kenya?
For us, this process started some times back, and I remember around 2013, we presented a list of list of the eye drops to the ophthalmic services unit, and especially for child eye health, when that was supported actually by Seeing Believing, when we were actually engaging the hospitals and asking them if they could provide the drugs. And the first question they're asking, how can we provide these drugs? We don't know where to purchase them from. KEMSA doesn't have them. So we presented this list to the ophthalmic services units and presented, of course, our challenge. And again, as I said, it is a concerted effort by other eye NGOs. I know, for instance, the Fred Hollows Foundation and others have also been pushing for the same. And we have also been discussing this during our INGO forum as one of the issues that we need to push for. So it's until 2016 that the ministry actually came back to us and said, now the list has been included. So that has been the process, but I can say it has taken long, but of course we are happy that eventually it happened.
Lovely, thank you, and congrats. I've got a question here for both of you from Bo Wafi. So he's asking, basically he says thank you both for both of the presentations. You've articulated it very well. But his question is, how in your projects, how do you manage to keep your staff? Because this is a challenge for many programs. And I think it's sort of how do you sort of stop staff from leaving the projects, and how do you kind of cope? How does the project cope with staff retention? So should we start with Deborah and then go on to Alice?
Sure. Staff retention is a challenge, especially for Zimbabwe, considering the economy, where we have experienced brain drain. We do have ophthalmologists, yes, and more being trained, but the probability of keeping them in country might be very low. However, what we tried to do through the project, there was a lot of training, especially for ophthalmic nurses. This is also more of an incentive where they become more involved. It becomes an incentive for them to be trained. And the fact that they were also involved in new initiatives such as the RAB and received some certificates for that was also an incentive for them. I also found the project very interesting, but I cannot guarantee staff retention in Zimbabwe or in eye health. It is a big challenge and will remain to be a big challenge if the current economic situation does not change.
Thanks, Deborah. And Alice, over to you on the same question about how do you sort of retain staff and keep them engaged in the project?
Yeah, surprisingly, yes, this is supposed to be a challenge, but I've been in this program, I'm working for Operation Eyesight for the last 5 years, and we have retained the people that I found there. They are still there working with the government. And one of the ways of motivating and, of course, giving them like incentive is we support them for continuous professional development. We support like the ophthalmic work, the ophthalmologists or the cataract surgeons, even the nurses to attend the ophthalmic conferences in the country and sometimes outside the country, where they attend and present their own papers. The other motivation that I've seen of something that is making them stay where they were posted is that most of them work in their home areas, within their counties. And so because they have their families there, so the issue of moving out, I've not seen it. But probably, yes, it's a problem in other areas, but I've not experienced it.
Great, thank you, Alice. Okay, we're a little bit over time, but we have so many questions coming up. I'm sort of reluctant to end just yet, so we might just take a couple of quick questions finally, and then we'll wrap things up. And if you do have questions, obviously, you can email me and I can pass them on to our presenters after. But a couple of sort of final questions. We've got one from Joseph Magezi, which is for both Deborah and Alice. He wants to know a little bit about follow-up. So from when patients have had the treatment, either the surgeries or the spectacles, what kind of follow-up are they kind of coming back into? What's kind of follow-up, and how is the follow-up for patients working within the projects? So again, if we start with Deborah and then go on to Alice to give you each a bit of time to go through that.
Okay. In Zimbabwe, under the SiB project, in order to strengthen the aspect of follow-up, we developed, in partnership with the local bank, the patient management system to ensure that we wouldn't drop our patients. We would know when the patients are supposed to return. And because we had the coordinators in these various units coordinating the project, these are the people responsible for sending reminders to the patients, following up. And when it comes to the cataract surgery, which is important when it comes to follow-up, of course, we always have the day one visual acuity check, and the patient is discharged. Then we have the 2 weeks, which means the patient is supposed to come back at 2 weeks post visual acuity, as well as the 6 weeks post visual acuity. This has been happening in the 3 eye units. However, like I mentioned earlier, the challenge has always been the transport, especially when this surgery has been done and everything is perfect. It's very unlikely that that person, if they don't have money, will return back for post-op VA at 2 weeks and 6 weeks. However, what we did was we raised awareness with the village health workers so that they could continuously send out this message in terms of the importance of follow-up. And because the district ophthalmic nurses were also trained to enhance their diagnostic and refraction skills, they were also capacitated to conduct or to review an assessment of patients so that the patients don't have to travel back to the provincial base hospital, but could be assessed at their local district hospital and only referred when there was need for the ophthalmologist to attend to an issue. So that's how we managed the follow-up. But in some cases, for example, for pediatric patients, follow-up was also done using a telephone or mobile phone, just phoning to find out how the patient is, depending with their condition.
Great, thanks, Deborah. And Alice, over to you. Would you like to talk a little bit about the follow-up that happens for patients within the project?
Yes, I think I will agree with the person who has asked that question, that follow-up has been a challenge. But what we have done so far is that we have engaged community health volunteers. These are people who are within the community and have been they work as in the area of health, and they are trained in primary eye care. And since these people are actually in charge of a certain number of households, I think in Kenya, once the community health volunteer is in charge of about 100 households, so they know once they mobilize these people to come forth for eye services or surgeries, they know them very well. So we are now using them to help us in the follow-up. Again, we discussed this issue in our last review meeting with our partners because, as I have said, it has been a challenge. And I have seen some improvement since our meeting. I've seen one of the eye units now has assigned somebody to do the calls, for follow-up, for patients who need reminders to come for the follow-up. So I am seeing an improvement in up to 2 weeks follow-up. 3 to 6 weeks follow-up is still a challenge for us, but I believe one thing that we are going to do going forward, and we have agreed this with our partners, is to engage first, is to ensure that follow-up component is part of the program from the very beginning, and then we identify the CHVs who are going to be, engaged in the program in identification, mobilization, and all that, and also updated and who has come for the surgery, who has not come, and that communication to go on in between the facilities. It's a model we are trying to also introduce in Kenya, Operation Eyesight model. We call it hospital community hospital-based community eye health. This is where we do clustering of a district. We identify around the health facility, identify specific community health volunteers who work with us throughout, ensure that we have combed the area in terms of people who need surgeries. The follow-up has been done until the end. So I believe that model will work for us here in Kenya.
Wonderful, thank you, Alice. And that's a lovely sort of moment to bring this webinar to a close. I would love to continue discussing and talking with all of you for the rest of the afternoon, but I know that with some time differences it's getting quite late for some people. So I'd like to end by thanking our two presenters, Alice and Deborah, for their comprehensive presentations and the responses to all of the sort of varied questions. Thank you to my colleague John for all the technical support, and thank you to everyone who's participated. I really appreciate you all taking the time to be part of our Seeing as Believing learning community. And if you'd like to share your own sustainability strategies with the Seeing as Believing community, sustainability is one of the themes for the next Seeing as Believing newsletter. So you're welcome to submit articles to me by the end of June. Then I'll include them in the July newsletter. And I have just one final favour. I'm now, in the next 5 to 10 minutes or so, I'm going to email all of you a survey based around the Seeing as Believing webinar. So if you could please just take 5 minutes to complete it, as your support for these webinars does make them possible, and I think your feedback helps us to improve them and make them more useful and interesting for you. So thank you again, and I look forward to seeing you at future Seeing as Believing webinars. Thanks all.